when we think about safety and about what makes a space safe, one of the things that's very important to remember is that for humans, typically the biggest threat is a social threat, right? We are very, very concerned about what other humans think of us, right? Ostracization is of the same caliber as intense physical harm, even death, right? And so if we want to make a space safe, we don't mean just safe from physical harm. We mean safe from social ostracization. How can we really turn up the volume on the sense that all of you is welcome here? Very, very powerful form of safety in social safety. Thank you for sharing that, Rosa. We have a couple of the things that have come in here. I would like to hear more about the body's tendency to create physical pain when the visceral pain becomes the threat. Oh man, that is one of my favorite things to talk about. So we will definitely talk about that more. That's a big chunk of today. And then another piggyback question there. How can we as therapists help to exact permanent changes and releases of that physical pain? Fascinating question. How do we create permanent changes? I'm gonna plant a seed right here at the beginning before we kind of jump into our slides based on that question. I think it is important for us as wellness practitioners to understand our own limitations. And I, in fact, encourage you, all of us, to put the idea of making the changes that we bring to people permanent, to putting that goal off the table. Because whether or not a change is permanent in the person that you are caring for is not necessarily up to you. In fact, it's almost certainly not up to you. And the more that we get into this mode where we can permanently fix something for someone or permanently shift something for someone, that can be a dangerous place to operate from as a wellness practitioner. I mean, how about this? Just by a quick show of hands, how many of you have ever experienced kind of practitioner burnout, where the giving it takes to do your job just kind of wears you down? Yeah, it's an easy thing for us to experience. And in my apprenticeship program, we talk about this a lot, where we separate the terms healing from soothing. Healing from soothing. Both are valuable, but if we get too caught up in a kind of how do we keep people permanently soothed, that can be a messy place for us to be as practitioners. So I love the question, and I understand the spirit of the question, but I wanted to say, let's take that idea of creating permanent change off the table. There's a better way to approach that, and we're going to explore that as we talk more today. Okay, and then let's look at one more question before we get into slides. How do we reorient the mind and body to have permission to be okay with big feelings or visceral responses? So the short answer, because obviously last time we talked a lot about this, right? That we have internal sensations, and then we can have a little war over those sensations if those sensations themselves have become threats. And so to reorient the mind, as this person says, to be okay with big feelings, there's a couple things that are required for that. First of all would be what we'll call social mirroring, right? We need at some point to have our experiences reflected, or at the very least modeled, right? If I'm having an experience and I can think of a time that I saw somebody else having that experience, that makes it much easier for me to put it into context, to make sense of it. And in fact, it's one of the things that we are lacking right now, both in our wellness community and just in our culture at large, is that there's not a lot of mirroring of big, uncomfortable feelings. We're actually quite a reserved culture, as it turns out. So yeah, social mirroring, that's one of the big ones. And then the next thing I would call experience. That the more that we can have experience of those things and start to see that the outcomes are not necessarily what we fear them to be able to have an experience of our expectation of an outcome of feeling a certain way versus what actually happens when we feel a certain way. That's the other thing it takes to kind of reorient that. And again, that'll be part of our exploration today. And then one last thing, I see that Mitchell has raised their hand. Mitchell, did you have a question?
Oh, no, sorry.
Oh, no worries, no worries, no worries. All right, well, tell you what, I'm gonna go ahead and bust into our slides now then. So let's turn that off and let's share. All right, can everybody see that okay? All right, excellent. So as I discussed last time, one of the things that I want to get a clearer picture of today is pain. Because, I mean, obviously, when people are coming in to see you as a massage therapist, a huge portion of your clients are coming to see you because they have pain. And, you know, ostensibly, the reason we come to a massage therapist is to reduce our pain. And obviously, many of you have had many experiences of doing successfully just that. But pain is complicated. And the relationship that our neurology and our neurobiology and physiology have with pain means that the pain isn't always the bad guy. And we want to have a really clear understanding of how pain signals are generated and why they are generated before we necessarily decide not only how to reduce people's pain, but whether that's really actually what they're coming to us for. So the most important thing to understand is that the conventional model of pain, which says that a tissue has been damaged, the nervous system registers that damage, and then gives it a pain scale for you to react to. That it tells you, pain is telling you what has happened to your tissues in the past. They have been damaged. This is fundamentally false. There is a portion of the pain experience called nociception, and that delivers signals to your nervous system about what's going on in your tissues. But nociception by itself is not responsible for the pain experience. And in fact, I think, again, well, I'll ask the question. Have you ever, either yourself or in a client, encountered a situation where there was a great deal of tissue damage, but asymptomatic damage? There was no pain associated with that damage. Has anyone ever seen that in someone else or experienced it themselves? Yeah, it's not an uncommon experience. So instead, if pain is not there to tell us about what has happened to our tissues before, instead it is there to tell us about what it thinks, what our brain thinks is going to happen because of a variety of factors. Pain is essentially an expression, a complex expression of threat. Something hurts when we're scared of what might happen, not because of what has happened. And this has been studied in a variety of ways. And what I'm going to show you next is a couple of the interesting data points that really indicate this very clearly. So what you're looking at here, this was actually a study about imaging, about medical imaging. But this very interesting piece of data came out of it, which is that in the age ranges that you're seeing across the top there, across this, the top of the chart, they have found that imaging kind of random people has uncovered a lot of these diagnoses, right? Disc degeneration, disc bulging, spondylolisthesis. And that as age goes up, we see more and more and more people that have these conditions, but are fully asymptomatic. They are not in pain because of these conditions. And we can see that, you know, when we start, especially when we start getting up over 50, we're looking at a lot of people, especially for some of the big ones like disc bulges and disc degeneration. And this throws a huge wrench in our understanding of how pain is generated. So if a client comes in and says, oh, well, my back hurts and it's because of this, you know, this bulging disc that I have. Now, that is part of the client's narrative about what they have experienced. And the fact that they have a disc bulge may be entirely true, but it is not fundamentally responsible for their pain. If it was, then all of these people on this chart would be in pain. So before I go any further with that, actually, I'm just going to come out of here just for a second. Does anybody have any questions about that concept before we get any further? Anything that we want to explore around that any further? Okay.
Looks like Daniel had a question.
And I see Karen's got one. So I haven't seen Daniel, but let me. Okay. Karen, what do you got?
Hi.
Oh, sorry, Karina, apologies.
So I've experienced personally pain, like anticipating someone else's when they're about to fall or something, like my own children, in a place that I've had trauma before. So that's
Absolutely.
something that I feel is very relative to what you're discussing.
Absolutely. You know, I have a client recently who was in a horrible car accident. And one of the things that she reported in the aftermath is that when she'd be doing her workouts in the pool, whenever she would see other people doing certain lifts with their pool exercises, that it would hurt. And she was really confused about that. So yeah, absolutely. Absolutely. Akemi, any questions?
Yeah, so I'm curious if you can just go back a little bit about the nociception.
Yep.
And is that the stimuli of what happens in the moment to the actual wound or trauma that might be there? And then are you saying that the amplification of the pain is something that, like the narrative we're telling ourselves, that we're telling us about the future? I kind of need like a little more what you mean by that.
So we're gonna, the answer to that question is coming, but to answer the first part of the question, yes, there are structures in your skin in particular that are there to measure things like chemical reaction, pressure change, heat change, and when that gets severe or extreme, nociception can, that's how we describe the transfer of those signals. So that is a structural signal transfer between brain and then tissue that happens in the moment, yes. But then the rest of it, again, we're going to look at some slides in a second that'll bring all that more clear. And then just make sure there's anything else that needs to be clarified before we go on. I recall learning that pain is a learned response. Have you heard this before? Absolutely. Absolutely. And our experiences of situations and our beliefs and our language and our social makeup and so on and so forth have a lot to do with what we start to define as pain and what registers as pain in the body. Okay. All right.
And then Daniel had a question.
Oh, Daniel. Sorry. Daniel. Nope, you're good. You're good. Daniel's good. All right. Excellent. So let's get back to it. Okay. Oh, wait. Sorry. Let me get rid of this. So I also wanted to show, just on that same idea, that along with this kind of tissue degeneration stuff, all the way, I've got studies here going from 1980s all the way up to 2010 that indicate a lot of these common postural and tissue-related conceptions about how we feel in our bodies have turned out not to be clinically reproducible, right? A lot of our basic assumptions about things like, you know, lordosis and neck curvature and bad posture and even pregnancy, that these things do not actually have a significant correlation with an experience of pain when we study them in a double-blind way. And I got to say, you know, guys, data like this is part of the reason why I started thinking about trauma more in my own practice, because I realized that while structure tells a story that can be useful to us, this relationship between structure and pain not being what we thought it was means that structural medicine, if it wants to be effective in the long term, has to change its tune a little bit. And it's these kind of observations that really bring that home for me. And so, by the way, if any of this, if you would like a bibliography of any of this afterwards, please let us know, and I'd be happy to send people my study link list that has all this stuff in it, so you can peruse at your leisure. I would like to now introduce you to a pain researcher named Lorimer Mosley. Lorimer Mosley. He's from Australia, and he has a book called Explain Pain. And this one I have is called the Supercharged. So this is the one for clinicians. There's also another one just called Explain Pain, which is for kind of regular folks. So Explain Pain Supercharged, or just Explain Pain. And it is a brilliant handbook for truly understanding how pain manifests in the body. Very, very smart dude. And he's kind of part of the emerging science of the biopsychosocial model of pain. Raise your hand if you have heard that term before, the biopsychosocial model of pain. Yeah, it's starting to catch on, and in fact, the San Diego Pain Summit, one of the, I mean, if not the most kind of lauded conference on pain research in the country, now only admits speakers who are kind of part of that biopsychosocial model research. But again, it has to do with this understanding that pain is not purely structural. So this slide you're looking at comes from Explain Pain, and it's called the Bilby in the Bathtub model, which is to say that, you know, if we've got this dude sitting in the bathtub with all of these horrible creatures, and the bathtub is full and crowded and scary and messy, but when he sees the Bilby, this tiny little cute marsupial guy, is it a marsupial? I think it's a marsupial. As it gets ready to jump into the bathtub, he freaks out because now it's going to overflow. But it's not really the Bilby that's the problem. It is the load in the bathtub and its interaction that's the problem. So the Bilby in the bathtub model, and it's a really great way of thinking about pain. And so, why isn't that going? Ah, there we go. And this gets us to where we can really start looking at the nitty-gritty. This is also a page from Explain Pain. So he calls it DIMS and SIMS. That stands for danger in me and safety in me. And that what the nervous system is doing at any given time is it's trying to calculate from a variety of sources the credible evidence that you are in danger, and then weighing that against the credible evidence that you are safe. And whenever a new piece of data skews that towards being in danger, the data, the piece of data that does that may register as painful. That's the Bilby in the bathtub. You know, this is this makes things a little more complicated, but it also allows us to have a much better understanding of what people are actually experiencing. What is the evidence that I'm in danger? What is the evidence that I'm safe? An example that I like to use in my program is if we imagine a kind of Serengeti watering hole, you know, where the antelopes approach the watering hole to drink, and the crocodiles are waiting in the watering hole to grab them. And a crocodile is a terrifying creature, and especially if you're an antelope and crocodiles regularly eat your kind, and you have seen many of your kind get eaten by crocodiles, that kind of prey fear, that prey species fear of crocodiles is built into you. However, antelopes also know how fast they are. They have lots of experience of being able to bound away from danger. And so invariably, the antelopes do a calculus where they go to the water because eventually the danger of being thirsty outweighs the danger of the crocodile. And this idea that I have confidence in my own ability to get away from the crocodile makes the crocodile a lot less scary. And so we take something that is objectively fearsome and dangerous, a crocodile, but when we put it next to evidence of my own safety, I start having a different experience of that situation. So let's explore this board here just a little bit. You'll notice that it's broken up into all these different categories, right? That when we talk about pain or things that indicate danger and safety, physical sensation is only one of these categories, right? So that's things happening in your body is number 7. And all of these other things have relationships to your level of danger and or safety.
Actually, if you guys would like, I'll get a copy of this and send it to you via email. This is pretty useful stuff, I think. It's also kind of hard to read from where I'm sitting.
Yeah, are people having a hard time reading it? Oh, okay, all right, noted. Well, how about this? I'm going to go ahead and go through a couple of them then, the ones that I think are. So first of all, the categories are, number 1 is things that you hear, see, smell, taste, or touch. Right, so things that your senses perceive in your environment. 2, things that you do. Actions that you take. 3 is things that you say. 4, things that you think and believe. This one is really, really important when it comes to trauma victims, or trauma survivors, sorry. 5, places you go. Places are incredibly important in terms of kind of triggering our sense of danger or safety. Number 6, people in your life. It's one of my only complaints about this particular thing is that to me, it seems like that one should be higher on the list. And then lastly, of course, things happening in your body. Now, one of the things that I want to point out about this that's very interesting is that different people can have the same thing in either category. So for instance, in this case, how about this? By a show of hands, raise your hand if you are uncomfortable in hospitals. Raise your hand if being in a hospital makes you uncomfortable. Okay. Raise your hand if being in a hospital makes you feel comfortable. Yeah. And then for others of us, it may just be a neutral experience. But depending on your life experiences, your being in a hospital may be a credible evidence of danger, or it may be a credible evidence of safety. And so when we are kind of assessing people's pain, one of the things that can be very useful to us is to have an understanding of what is truly threatening to them and what may have informed those threats. And actually, I want to bring up one that I have encountered frequently in my practice recently, and that I think is a very important thing for us to have in mind, I think especially as manual therapists. Actually, I'm going to come out of this slide here for a minute so that we can have a face-to-face chat. All right. So raise your hand if you have ever had a client, like a trans client, who engages in chest binding. Has anybody ever worked with someone who has before, currently, or has before engaged in chest binding? Yeah. So chest binding, for those who are unfamiliar, is the practice of using some kind of a cloth or material to wrap the chest in order to diminish the visibility of breasts. And there are some very interesting physiological, social, cultural intersections happening in this practice. Because on the one hand, I think for any of us who are not trans, the idea of wrapping something around your midsection tightly and it's staying there for a long period of time, we can imagine that this would be physically uncomfortable, right? That this might start to inhibit things like breathing function or movements of the shoulder girdle or whatever, right? A variety of things. And so our instinct may be to place something. If we learn from a client that they engage in chest binding, if we're trying to put up some stickies on their imaginary DIMS and SIMS board, we might put chest binding into credible evidence of danger, right? Things I do with my body would be this kind of restriction placed on my body. However, if a person is wrestling with the kind of gender perception or how they're perceived in terms of their gender, then the act of being flatter in their chest might make them feel safer. And in fact, it might make them feel so much safer that they don't experience pain as a result of that action. So just like the 70-year-old who says I have back pain because of my disc bulge, we have to take a look at a person in that kind of situation, in a chest bind situation, and say, and step back from our assumptions about what may be causing their pain, because it might not be structural. There may be a structural component, but it's more complicated than that. And so in a way, what I'm suggesting here is that understanding the kind of DIMS and SIMS layout gives us a chance to pause about our own assumptions, or even, I'll even say, our own education, right? You guys have all been through extensive education to do what you do well. But I think we would all agree that parts of our education has included a lot of asking us to think about pain in terms of structural quality. Oh, look at that lordosis. Actually, I think pregnant women also go through a similar thing. It's just assumed that being pregnant means that your back is going to hurt. And it's true that pregnant women often have back pain. But then this idea that it's because of their pregnancy, again, even that can be stigmatizing. And so we need to be able to place a pause between what we see in our clients and our own assumptions. Any other questions about that before we carry on? Okay. So, okay, so credible evidence of danger, credible evidence of threat. And we talked about chest binding. Okay, excellent. So let's go back to this. So I want to revisit this then a little bit. So if we are working with a traumatized client, and again, for our purposes, what I'm suggesting is that when we say traumatized, what we mean is somebody who has, as a function of threat, needed to enter a shutdown phase, that their sympathetic nervous system was unable to resolve a threat and therefore needed to shut down, either to find a new pattern or to play dead, such as it were, quote unquote. And that in order to kind of rebalance the nervous system, in order to get out of that trauma response, we need to pass back through the sympathetic nervous system, to pass back through our felt fight or flight reaction. This means that part of your intake with someone, part of how you start to unravel why they're in your office in the first place, means needing to get a sense of what is threatening them. What is it that makes them feel unsafe? And so one of the things I recommend adding to your your intake form or to your initial conversation is some version of the question. You know, I often say this to my own clients: what would it take to make you feel safer? What would it take to make you feel safer? And sometimes, you know, I'll ask this in a very literal way, right? Like having the lights down, you know, or whatever, or having the lights up, or no talking, or more talking. I mean, you guys have heard that kind of stuff before. But I often like to put it into a kind of fantastical situation as well. I'll often add things like be creative, you know, or sky's the limit. If you could do anything, if you could be any shape, if you could, you know, if I could be any shape, if this room could be anywhere in the world, da 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 da. There's a lot of kind of almost childlike conversation we can have around what really would it take to feel safer, and then to start seeing if we can extrapolate a little bit about what that is. And one of the things that I'm going to suggest kind of specifically that we all keep an eye out for is when a client reports a need to calm down, like when they report that they feel stressed a lot and can't calm down, and what they need to do is just calm down, I find that that's a red flag statement for me. Because if someone is stressed and feels like what they need to do is calm down, ironically, it may be exactly the opposite. That there is an excited, an aroused state somewhere in their body that actually needs to happen before they will be able to calm down. Right? It's also like if you encounter those clients for whom phrases like, oh, there's just so much negativity, I need to get away from the negativity, right? Or people that have a kind of always sunny, oh, I try to have a good attitude, everything is fine, right? These kind of, you know, presentations may indicate that there is an arousal response, that part of the reason they're hurting is because that their arousal response is being squelched. So someone asked at the beginning if I would explore a little bit more this idea of pain as a solution to visceral response. Okay, so let's go into this a little bit. Actually, I'm going to come out of my slide again because this is I'll be able to take some questions around this. So imagine for a moment that you are in a situation where, let's use anger. Anger is a really common one. That physiological responses that you associate with anger. Would anybody be willing to just give me a couple? What are some physiological things that you associate in your body with being angry? Anybody? Go ahead and type it out or raise your hand. Let's see if we can get a list going here. Heart rate increase, absolutely. Flushing of the face, heat in the eyes, crying, absolutely. Jaw clenching, sore throat. I love all of these. Yes, constricted throat, wonderful. Okay. So if I have, through my life experiences, learned that when my anger, when something happens that makes me feel like I need to protect myself, or an anger and aggressive response comes on, and I have learned to tag things like a constriction in my throat and heat in my face as being angry. Now what happens is I need to make sure, if I've learned that doing that is dangerous, I need to make sure that as those sensations come up that I don't act on them. Right? Maybe even just seeing the color change in my cheeks might actually put me in more danger. Right? Remember, I've encountered a threat that I cannot overcome. So if the threatening thing sees my cheeks flush, that might put me in more danger. Okay? So if that has happened, imagine for a moment that you were having your anger reaction and suddenly your body was as powerful as you needed it to be. So your throat is tight and your cheeks are flushing, and suddenly you get a massive injection of power, right? Suddenly you're stronger, you're faster, you're more capable. What would be the potential harm in that? What, is there a reason why you wouldn't want to be more powerful in that moment? Anybody? Can you think of a good reason why you would ever not want to be more powerful in that moment? Yeah, hold on. I'm gonna unmute you, Karina. Okay, go ahead.
Okay. Well, being a parent, you know, sometimes I'm really angered by my children, and I don't want to hurt them. So.
Right. Yes, absolutely, absolutely. And then, you know, because your anger might make you do something you'd regret. I'd probably hurt somebody. I don't want to hurt anybody. Now, and this is a great example. This is kind of one of the things I've noticed in my own practice is that physiological responses of anger are among the most commonly suppressed ones, among both genders, across all ages, across all genders, all ages, everything, right? And there's this belief that if my anger responses come on, right, if my cheeks flush and my throat gets tight, and I would do something that I would regret. And because of this belief, the one of the body's responses to this is to make you less powerful. To just cut your feet out from under you. Make it so that you don't have the option. I'm going to give you a case study, an example from my own kind of client roster. This client was in a kidney surgery. And as part of this surgery, it had to have a shunt implanted in their kidney. Not a pleasant experience, if anybody's ever been through that. And after the surgery, when the shunt was being taken out, the nurse told my client, hey, just so you know, this is probably going to be the worst part. So when the shunt comes out, that's the part that you're really, you know, just to kind of prepare you, full disclosure, this is going to be an awful experience. And so, okay, I'm ready. So she pulls the shunt out, and for sure, it's the worst. It is the worst pain this person has ever experienced. And what she found in that moment was a debilitating nausea took over. And as we talked about it more, she described how she had this initial reaction to hit the nurse as hard as she could. That she wanted, you know, here was a person inflicting unbelievable pain on her. And what she wanted to do was reach around and just punch her in the face. But obviously, we know punching nurses in the face is a really bad idea, right? And so this kind of prefrontal cortex ego control says, oh shit, you're about to do something we desperately need you not to do. How are we going to prevent that? Well, one great way is through a dorsal vagal response that makes your digestion go crazy. And that nausea was debilitating. She collapsed in a heap and could do nothing for about 30 minutes. But she successfully didn't hit that nurse. Now, what's interesting about this is in the aftermath of that, where is the acceptable place to talk about how angry you were, how violently angry you were at the nurse who saved your life? There's never really a good place to talk about that. That's an unreasonable thing to feel, or so we believe. And you see what I'm saying? This is how it starts. As soon as we have a belief pattern that says the way that I feel is unreasonable. Because the way I always like to say it, feelings cannot be shameful. Feelings cannot, under any circumstances, be shameful. Actions can, but feelings cannot be shameful. And I would argue that this is the cornerstone of trauma. The cornerstone of what we think of as trauma is our belief that our feelings can be shameful. So this client of mine, to kind of continue with the case study, we walked through some interesting processes together, some coaching processes, and when physiological responses that she associates with anger, things like heat in the face, pressure in the throat, in fact. When those things would happen, if anybody were to call attention to them, she would immediately get nauseous. And we had several experiences in our sessions that whenever I would call attention to those physiological responses, she would feel nausea. And we had to work all the way through that. We had to go through lots of sessions where I had to be completely okay with making her nauseous, with doing things that made her feel nauseous. And this kind of acceptance of like, yep, I'm asking you to do something that's uncomfortable. You are uncomfortable in my presence. And I'm not going to fix that for you. I'm not going to make that go away just yet. And there was an understanding around that that allowed us to start seeing a bigger picture. But yeah, this pain process is part of this system. I'm having a physiological response, but I can't let it move me. I can't let it become part of my behavioral matrix. And if I don't have a model for how not to do that, the fail-safe is just to cut the power, right? The fail-safe is to destroy the joint, make it unusable, to hurt so that I don't move in the way that I think is so scary. As I'm fond of saying to my apprentices, the nervous system will do anything to protect you, including hurting you. So before we go any further into that, anybody have any thoughts, questions? Let's take a breather just there for a second and share what's going through our minds.
It's like Sue and Stacy Ann have their hands up.
I don't actually see any hands up.
They're physical hands up.
Oh, physical hands up. Sorry. Stacy, you said?
Old school. Yeah, I'll unmute. Sue, you are live. Go ahead.
Hi. When we're talking about anger and having something happen to then prevent you from acting, it's bringing to mind the many videos online of policemen's interaction with people and how they, instead of having that mechanism come in, they just escalate the problems all the time. And it's like, to me, I think the police need to do a lot of anger management because they cause more problems that are actually in existence because they don't have that mechanism kicking in to get the situation to be calmed down. I see more so that it's like maybe it's fear-based. They're into a panic state of coming from fear, and that's what really escalates their anger in these situations. And I find it something that maybe a lot of police departments need to recognize, that their people need help in that regard.
Yeah, that's an excellent point. That's an excellent point. And in fact, several of my clients are police officers. One of the things that's needed in terms of helping people in that function, because again, this is kind of what I'm getting at, folks, that if the emphasis is always on calming down, you need to calm down, you need to regulate. That can't solve all the problems. That's essentially asking a person on that graph that we looked at, that's essentially asking a person to go from their freeze shutdown state kind of all the way to restoration or back to social engagement, right? Again, what too many wellness programs are touting is the idea that is reinforcing the idea that your basest emotions like panic and rage, that those things are unacceptable, rather than have them and let us have them in a skilled way. Now, obviously, we're getting kind of out of the purview of a lot of massage therapists are going to be dealing with, but for understanding the big picture, this is the kind of stuff, you know, when you see your clients having big emotional reactions on the table, let's unpack some of that. Let's unpack some of that. Let's say let's say you have a client who in fact is in a, I'm gonna amalgamate some of my clients into like a fictitious case study, all right? So let's say we have a person who is in the role of a police officer, right? So they carry a gun and they encounter frightening situations all the time, and they have a huge amount of responsibility to care for a broad public. Now, let's assume that they are a good person and they don't want to hurt anybody. And so when they are in a situation where they feel threatened and they feel those kind of mechanisms for anger, for aggression, right, skilled aggression rising, that what they've learned to do is suppress those things. I have to make sure that I don't act on that. One way, and we're going to explore this specifically in a moment, one way is to take the non-dominant side of the body, in particular the non-dominant arm, and to freeze it. So that the non-dominant arm, rather than being used as a power-producing limb, becomes more like a splint, shutting off movement options and overall diminishing how much power you can get from your environment, from gravity and friction, mostly. So this means that, okay, my anger signals are there, but if I let myself be at full power, I could do something really bad. So I have to be at like 40% power. Now I can kind of negotiate that more safely. Now, this works. I tell you folks, so many of your clients are doing exactly what I just described, by the way. Okay? This works. But if you walk around with your non-dominant arm acting like a splint all the time, and the muscle tissue associated with splinting it to your spinal column, we'll go over this more in a moment, splinting it to your spinal column active all the time, you start to create pockets of instability in the body, which generate then themselves new threats. Let's say our fictional case study person has been doing this for 10 years, and they're still on the job and still encountering all this panic and still trying to ratchet themselves in, you know, less and less and less powerful so they don't hurt anybody. Well, eventually, the act of splinting while they're facing a threat is itself going to start feeling painful, because that's the new threat. Now the fact that I can't be as powerful as I need to be to resolve my threat, that's my next layer of threat. Now my shoulder hurts. Can you guys see the progression I'm talking about here? So if this person comes into your massage table and you immediately identify with your very intelligent hands, oh man, this person's back is all knotted up on the left side and their scapula is retracted like crazy and their tricep is all ropey. I need to release this for them. Well, when you release that, you better believe a bunch of interesting stuff is going to happen inside their body. Because that arm was never behaving like that because there's something structurally wrong with it. It was behaving like that because their brain told it to behave like that for a very specific reason. You guys following me? So this is an example, but this is the process. This is the process. This is essentially, this is all pain and this is all behavior. This is all how it works out in these layered threat responses where we're calculating how do I stay safer in this moment? And remember that social pressure, how do I make sure the people around me don't cast me out? That's the biggest threat. That's the one. Okay, so let me just look at the questions here. We had a couple questions come in.
Kate's got one as well.
So we've got, okay, so what we have written down here, can I give examples of the skilled way that you allow them to have them? And by them, I assume you mean the anger responses. Is there any research on pain metrics in cultures that have different ways of managing anger or fear? There is, it's very interesting. So what should people do to express rage in a healthy way? Okay, so we have limited time. These are excellent questions. And again, I'll say shamelessly, I teach a 3-part total of 60-hour course that explores this stuff in great detail that absolutely goes into that question. You know, there is a safe way to embody any feeling. There is a safe way to embody absolutely any feeling. But there are some rules we need to understand about how those feelings come down the body. And we're going to poke at that a little bit in a second, but the big conversation is at least 20 hours long. So let's see here. You said Kate had something?
Kate Johnson has a question. I will unmute her right now.
I got her right there. Kate, what do you got?
Thank you. I wanted to ask you, you said that we would do well to put on our intake form the question, what would it take for you to feel safer? And is that actually opening up a can of worms? Because it's kind of out of the blue on an intake form. We're asking a lot of physical questions and medication questions on an intake form. And so with the virus happening, that's kind of a big question to ask on a form. So I'm wondering what your thoughts are.
I can completely appreciate that. And how you folks are going to manage your practices in the wake of the COVID crisis, yeah, there's still a lot to be learned. There's still a lot to consider. And what I can say is you are the best judge of what's going to work for your practice. So what I am suggesting is that if we know that people are going to be coming in to work with you in traumatized states, probably more of them in the wake of this practice, right? Then we want to be able to have an eye toward, I'll say it differently. We want to be able not to stay outside of the trap of equating structural change with a reduction in pain. Now, we have to compartmentalize our practice somehow. We can't be everything for our clients. And so you'll have to decide where you want to position yourself in that regard. But I'll say it more generally then. Rather than a question on your form, how are you, here's your kind of homework question maybe. How are you going to break out of the structural pain model of the past century? What is going to be your ante into the biopsychosocial model of pain? Doesn't mean that you have to do something, vastly different than what you're already doing, but how are you going to pause around your own assumptions with structure versus pain? Does that help, Sue?
Yeah, that makes a lot of difference. Yeah.
Okay.
I think it's worth stating explicitly that massage is going to be a can of worms. when you suddenly open your door again. That's asking a lot of anyone to sit on a table for 50 minutes and be touched by a stranger, especially right now when we can't go to Safeway without wearing masks. So I think it might be wise to get a jump on it, to crack open the door of, hey, this is weird, right? We can all experience the weirdness of this new situation. What do you need to feel safer right now? And that way, if they're saying like, God, I really hate having, the noise machine on. Can we please turn that off? They won't feel awkward about that, or whatever it is, right?
When we did this course a few weeks ago, helping practitioners move their practice online. On the first day, one of the things, because I've done lots of online presentations in my life, one of the things I said at the beginning was, because it was like right after California had gone to shutdown, like things had really just kind of exploded in the US. And so I said at the beginning, guys, let's not pretend this is normal. Let's not pretend like this is just a normal Zoom conference. It isn't, right? Like we are all going through some weird stuff right now. And so just know that my tolerance for saying weird stuff and behaving a little bit strangely is going to be higher right now. Like, act strangely, that's okay. Let's not pretend like this is normal. And so kind of going back to what you were saying, Sue, that's kind of what I'm getting at is, can we open the door for our clients by acknowledging, let's not act like this is normal, right? You're back at a massage for the first time after being in lockdown because of a viral pandemic. let's not pretend this is normal. And whatever comes out here is welcome here. Can we do that? Can we make something like that? We have a few more raised hands, and then we're going to take a little break. I'm going to unmute you, Mary A. Go ahead.
Hi, everyone. I feel like having a trauma-informed practice is really important for us. And
Yes.
what I do, if you don't want it on an intake form, I think that's fine. But I don't think it's really ethical to do a massage without knowing if the person on your table has a history of trauma or not. And I say that because, not that I really change much. If my practice is trauma-informed, I'm not really changing much. But knowing that makes me be sure that I am extra aware of cues that would invite a lack of safety for me to like pick up on their lack of safety, whether or not they are, right? They may not pick up on their signals of lack of safety, but I might, just through just through so many things that happen when we're touching people, right? So I'm the anonymous person. I can't figure out how to comment to everyone, and I'm having a moment. So I just feel like it's really important. And I work with a lot of trans and trauma populations, both, and the trans population is also a traumatized population. So the Venn diagram there is pretty big. And I would just like to say that I haven't had a single person be offended or ungrateful that I didn't ask about it. And in fact, that invited the safety. Do you have a history of trauma? Like, I just want you, and the other thing I say, I think this is helpful to know, hopefully, sorry if I'm talking too much. I always just soften and lean in and say, I want you to be sure that you feel in charge at any time. If we need to stop for any reason whatsoever and end this massage, that is fine. And I want you to feel empowered to say that, and just empowering them again about pain and touch. I mean, I'm sure all of you are trained on this. I have different training than y'all, so I don't know how much training we all have on that. So if that's helpful, that's just some of the phrasing I use. So.
Okay, thank you. That's good. Yeah, actually, a point you made that I do want to follow up on, and again, I'll just give a very brief description of one of my recent clients. Complaining of neck and shoulder discomfort. And as I was doing some manual exploration of that area, they were laying on their back. And we were talking at the time, and I was asking them how things were feeling. And their description of it was that it felt good. And with a very obviously practiced, chipper voice, this is good. Yeah, it's fine. It's good. I like this. However, the expression on their face clearly indicated that they were upset. Or at least, how about this? Even if we assume that my interpretation of their facial expression was my own bias, the sound of their voice and the words they were saying and the look on their face did not match. So however you wish to interpret them, they weren't the same. And so just like the last commenter was saying, at that moment, they could not articulate that they were uncomfortable or feeling unsafe, but I could see it. And so I knew that it was time to, let's try a different thing. And in my particular case, I ended up trying to call attention to it, and it ended up working out. But in other cases, I won't call attention. I'll just move on to something else, right? It's that, we talked about it on day one, right? This idea of a person can give you verbal consent, but that's not the end of the story. Just because they said yes doesn't mean that there's not more nuance to explore. And we want to have an eye toward that. Okay, so we're going to take a quick break. Let's say 10 minutes. So at 11:15, we're going to come back and wrap up. Go ahead and leave your screens on. I'm going to leave my screen on. I'll just mute it, and I'll see you guys back here in 10 minutes, okay? Okay, it is 11:15. Can everybody confirm for me they can hear me all right? We're all on board? Yes, excellent, wonderful, wonderful. Okay, so I often find that after the first hour or so, during the break and a little bit of digestion, there may be some other thoughts or questions or ideas that come up. Anybody else have anything they wanted to share or ask? I do see that somebody wrote me something here. it's kind of a long question, but the summation is sometimes people come in for massage and they might even kind of prepare you, the massage therapist, by saying that they might cry. Hey, just so you know, there might be some tears today. But what this person is saying is that the people say that, but then they often don't. And this person wants to be sure that they're not somehow preventing a release or something they're doing that's making it so the person can't get the release that they're looking for. I would say that it's a very complicated thing. A release is a complicated thing, right? If we go back to that DIMS and SIMS idea, you and your massage practice and your massage space are only a tiny fraction of what creates their kind of net safe versus not safe feeling. So you do everything you can, and you do your best to be a place where someone feels safe enough to be able to express themselves. But if they don't, that doesn't mean that you've done anything to prevent it. In fact, from my own personal experience with massage in particular, I find that I will often have I will feel emotional on the table, but it's kind of hard, for me in that space, it's hard to express it. And so, if you can tell that someone's built up in a way, just because they don't necessarily release it in a dramatic fashion, doesn't mean that you're not helping them process that in a way that feels safe. So I would release yourself of that responsibility if you're feeling that. Some other things here. I'd still like to know a few ideas for healthy ways to express rage. God, wouldn't we all? Raise your hand if you feel like you need a healthy way to express rage. I'm sorry, I'm gonna have to come back to that one, because I tell you, we start talking about that, it's all we'll talk about for the rest of the class. So I am gonna come back to that, but I promise I will come back to it. If pain isn't necessarily related to structure, why do things like learning to improve your posture often help reduce pain? Oh, this is an interesting one. Okay, posture is only partially about structure, right? We have so much social communication that goes into our posture. And even then, one posture that means something in one cultural context or in one cultural kind of region or demographic will be very, very different in another. So let's say that I go to some kind of wellness practitioner because I believe that I have bad posture and that the reason my back hurts is because of my bad posture, and I believe that. Now I go to my practitioner, and my practitioner, who is smart and has good posture as far as I can see it, and I have a lot of confidence in them, they tell me what I should do. Now I've created a relationship with this person where I can release some of the burden of having to figure out what I'm supposed to do. They take on that burden for me. They tell me what I'm supposed to do. And then I adequately recreate the shape of this person who I think is smart and healthy. Suddenly, I have all these data points for my belief that I am safe. Now, not one of them could have anything to do with the actual kind of deterioration of my tissue, but I will feel better. And so posture is one of those places I urge a serious reconsideration, guys, for us all, about how we think about posture and its relationship to comfort, because it is so incredibly subjective and so incredibly kind of cultural in nature. In fact, as we're looking at dealing with more and more diverse populations, right? I would say the two big ones that I think about are age and trans or non-binary, right? As a result of the kind of body modification stuff that they often engage in. But like for the aged, whose bodies change in shape over time, it's so easy to have immediate knee-jerk reactions about their discomfort being obviously because of the way their spine has changed over time. And then as trans folks try to navigate being in a trans body, the modifications that they do to feel safe, again, we can have these knee-jerk reactions of like, ooh, that would be uncomfortable. But posture is incredibly subjective, and it is made up of many, many pieces. We all need to take a long pause before blaming posture or crediting posture for how we feel. What else here? I found it can be as important as letting people know it is safe to express their trauma, to let them know they don't have to. Thinking PTSD clients that they have so much of their lives revolved around it. Thoughts on creating that balance in communication. Yeah, and I think this is a little bit what, now we've got a couple commenters kind of dancing around this idea that for some, they want a place to have their, where their trauma can be safely acknowledged. For others, it is less comfortable to have it be openly acknowledged. And we don't want to be in the business of forcing people into one position or the other. You know, I find that one of the things that I do in my practice, since I deal, I would say mostly with people in traumatized states. At this stage in my career, 70% of my clients are coming from pretty deeply traumatized backgrounds. And I frequently don't use the word trauma at the beginning anyway. I will often wait until, if they use the word trauma, then I will mirror that word back to them. But, or I will talk about trauma in general, not necessarily relating to them, to see if that word resonates with them. But I'll talk about like important events, or again, if I see some of the physiological telltale marks that we've been talking about over the course of this training, I might ask some questions. But yeah, I find that that one thing, the word trauma being a little bit loaded, and can we wait for them to describe themselves as that with that word, or can we wait to see how that word sounds in their ears before we necessarily assign them with it or assume it about them? How about this? And it's not an exact science. It's not, this is, you know, remember I said on day one, a very important thing I think is to make assumptions, to be able to trust yourself to make assumptions for the care of your client. And then if you find that your assumptions were incorrect, be willing to pivot kind of selflessly, quickly, right? Rather than defending a position that didn't work out, pivot to what your client needed without a thought. You can process your own kind of guilt or shame or concern about that later, but in the moment, make your assumptions, right? You're a good practitioner. Make your assumptions, but pivot when you need to.
Mary has a question.
Mary, you are unmuted, I think. Yes, there you go.
I really feel like balance and intuition and meeting a person where they are with language is important. I work in a medical setting. I've been on classes with everyone all week, but I'm also a naturopathic doctor, so I have a little bit of a different intake, right? So I recognize that we all have different types and styles of practice and scopes, right?
Yeah.
But I find that you don't have to repeat it. It's like a first visit check-in. Do you have a history of trauma? And you don't have to ask what kind, right? Like for them, it could be an MVA and it's a neck issue. But just asking that and then giving your spiel about how they're in charge and how you're, you know, whatever that looks like, I feel like for me, is a really ethical thing that has to happen. I just really feel strongly about it for me in my practice. And yes, that word is triggering, but I actually hate the word trigger. Like the word trigger. I wouldn't say it's triggering. I would just say it really pisses me off. Because then it makes us dance around what we're trying to convey to somebody without, I feel there has to be a certain amount of obviously like not saying discriminatory or inflammatory things, but I just mean when we approach a client with that open-hearted willingness to learn and be curious about what we're going to investigate and explore together, and by working to dismantle any charge that comes up around these words, by just diffusing it with calmness and kindness and that healing presence, you know, you're like, well, maybe we shouldn't use the word trauma. It's like, well, how did you use it? It's not always the word, right? It's how you're using it. Are you just like, you know, robot, oh, any history of trauma, like checking off your card, or are you engaged and creating that space, right? So yeah, these are big things. These are traumatizing times, right? Like we're all coping with our own stuff right now. And I just think that it's not just semantics.
I think that's a great
word, and it's not the you know, and you can't control if you saying the word shoe is going to trigger something for someone. And if you're going to walk around on eggshells about it, it will potentially take away from the presence you're trying to emit. And so I think it's important. That's why we take ethics classics on marginalized populations, so we better know those languages. So if we are recipients of, for example, white privilege, education privilege, we are using it mindfully and in a way that doesn't increase any more harm for people. I could literally go on and on. I'm sorry, I get on these tears. I will let you be the teacher.
No, because again, the issue of language and what language we use and who we use it with and how is a fundamental component of how we create therapeutic spaces. And as you pointed out, you know, your medical space, the space is going to have a slightly different feel than, say, the casual massage kind of mom and pop shop. Mm-hmm. And different people gravitate towards different spaces, and we as practitioners have to figure out what kind of language is going to help us connect with the broadest and most diverse population so that we're not shutting people out. And this is a balancing act, absolutely. And again, I'm thrilled that, for instance, in your case, that you have found that there is a felt sense and how you approach the trauma conversation that works beautifully in your space for your clients. And it is important. And in fact, it is that felt sense, as you say. How do you say it? Like, there's a felt sense of how we engage with people that when we talk about working with traumatized clients, that we all need to have a wider eye toward, right? Just simply going through our process, if we want to deal with what's coming to us after COVID, again, it was already there, but now it's bigger, and it's more open. And if we want to deal with what's coming to us, we need our felt sense to expand, and we need our ability to negotiate with our clients and with our language to expand.
And you know, I wanted to jump in before I forgot. I think that's a great comment, Kate. I really appreciate that. I think going into business again after COVID means almost assuming that our clients will be traumatized. I mean, how could you not be traumatized right now, right? You're stuck indoors without seeing your friends for weeks on end. But maybe, yeah, the word trauma is in itself kind of traumatizing, right? No one wants to think of themselves as being victimized by their circumstance. So I appreciate the kind of delicate balance between accepting the reality of what we're about to see, what we're all experiencing, and pinning a word to it that might not make that person feel safer. Okay, goodbye.
Okay, so anything else before, because I've got a couple more of those slides that I want to look at that go a little bit more into some of the neurobiology. So we're going to talk a little bit about right hemisphere, left hemisphere stuff. We're going to weed out some of the pop psychology and actually look at what does it mean to have a bihemispheric nervous system, which also ends up being a bilateral body, and what that means. So before we get to that, anything else? Clarifications, revisitations, hopes, dreams, frailties? No, we're good. Okay. So let's go.
Yes, back. I popped something on the chat.
Daniel.
There we go. Seems like a fine line we walk to broaden the conversation with client about their pain while staying within scope of practice. OBMT says psychotherapy is outside our scope and that talk techniques like hypnotherapy, Hakomi, etc., are psychotherapeutic techniques. Yes, okay. So this is a really tricky conversation because, again, you're absolutely right. There are legal boundaries in place for what qualifies in terms of insurance and prosecution, right? If someone's going to sue you for something that you've done, what can you be called an expert in versus not? There are boundaries in place here. And so I am not necessarily encouraging anyone to start using established talk therapy techniques in their practice. What I am suggesting is that if we are going to be trauma informed, right? If we are going to open up our spaces to communities who are broadly traumatized, if we're going to be fluent in working with any person, regardless of background, culture, race, ethnicity, gender, etc., then we have to be able to have some understanding of how pain and movement and body structure and emotional quality fit together. Because the legal world may want to separate these things, but your inner world absolutely does not. So even if we can't employ these things as practices explicitly in what we do, we need to know that they're there. We need to know what we don't know, at least. So how you personally choose to define your scope of practice and to make sure that you are positioned so that you feel safe, not being sued and making sure that insurance covers what you want to have covered and all that kind of stuff, that's going to be a very personal decision about how you choose to execute your practice. All I'm suggesting is, don't for a second think that because there's a legal boundary, that means your client is experiencing a boundary in their inner world along the same line, because they are not. Okay. So let me get back to the slides here for a little bit. Boom. Boom. Okay. We already went through that. Yeah, all right, so let's talk about brain hemispheres for a minute. So we've talked about the parasympathetic versus sympathetic nervous system response, right? And these are divisions of the autonomic nervous system. And what's been found is that the force of the parasympathetic nervous system, right? So the chemical cascade, the physiological behaviors, the kind of enforcement of a parasympathetic state seems to largely come from the left hemisphere of the brain. And then conversely, a sympathetic nervous system state seems to be largely enforced or produced via mechanisms of the right hemisphere of the brain. Now, this is interesting because we all have a neurologically dominant and non-dominant hemisphere. And in fact, one of the things that Reembody has devoted itself to is to really understanding how these differences play out in the sides of the body so that we can kind of trim our process and focus our attention where it's needed. But if we were to kind of sum this up a little bit in kind of plainer language, it means that these visceral sensations that we associate with sympathetic nervous system responses, right? I showed that big list last time. So all of the facial flushing, the heart palpitations, the stomach churning, all those things, the right hemisphere seems to be in control of that stuff. That felt sense of the inner visceral body is in the right hemisphere of the brain. And the parasympathetic nervous system, remember that when we go into shutdown, when we go into freeze state, the parasympathetic nervous system needs to overcome the sympathetic nervous system. Now that can be done via simply a very secure state of rest, and that's fantastic, good for us. But when it happens violently, right, when we must be sent into a freeze state from our sympathetic nervous system state, our parasympathetic nervous system responses are coming from our left hemisphere. Our left hemisphere has to kind of attack our right hemisphere in order to shut it down. And this can be an ugly process. How about this? Just by a quick show of hands, have you ever experienced a negative internal monologue? Have you ever caught yourself
daily, all the time?
Yeah. Have you ever caught yourself being pretty mean to yourself? Yeah, absolutely, absolutely. And this is part of that process. Remember, we talked before about pain, right? About how if you need to get shut down from being too powerful, from doing something that's going to put you in more danger, compartmentalizing areas of the body so that force is directed against your own body in a painful way is a tool at your disposal. Negative self-talk is also a tool at your disposal. It's not a nice one. It's a pretty blunt instrument. But if you need to shut down a sympathetic nervous system response, negative self-talk is one way to do it. Because remember, the left hemisphere, and we'll explore this more in a second, but the left hemisphere of the brain is the one that is normally associated with language, right? If we have a normally developing brain, right, without any kind of need for extreme plasticity where the right hemisphere takes over, the left hemisphere is their talking brain. And if your left hemisphere needs to turn to your right hemisphere and say, you need to slow your heart rate down because we're in danger, one way to do that is by saying, it's ridiculous. You shouldn't be afraid. Only an idiot would be afraid of that, right? And we can use this, because remember the dims and sims before? Dims and sims? We can use what we say or what we believe to create more danger or safety. And sometimes in the same thing can be in either category. So if your left hemisphere talks down to you when you have sympathetic nervous system responses, on the one hand, that negative self-talk can hurt, but if it keeps you safer, it doesn't hurt enough to stop doing it. So it's important to understand the adversarial nature of this process. You know, you think of yourself as you. We think of our clients as one person, but they are not. They are two. You are two. And those two people don't always want the same thing. And they are empowered to shut each other down. It's what's called mutual inhibition, right? The two hemispheres of the brain, the parasympathetic and sympathetic nervous systems, are empowered to be mutually inhibitive as the environment calls for it. This is, in my opinion, one of the most underexplored truths about how humans occupy space. So let's look at a little bit about what we mean, you know, separating some pop psychology from some real brain science. So first of all, as you probably all already know, the left side of the brain controls the right side of the body. It also controls the sensing organs on the right side of the body, with some weird exceptions for vision, which we can talk about another day. And then the right side of the brain controls the left side of the body. Now, there's some interesting nuance there, however, because the right side of the brain can feel the whole body. And again, in particular, the kind of like organ function, right? Whereas the left side of the brain is pretty specifically only geared towards feeling the right side of the body. And also of interest is that within the right brain is our perception of empathy. And in fact, it is closely related to our perception of self. A fascinating study was done, and it was found that people that can feel their own heartbeats, right? So the test was you had a heart monitor hooked up to the subject, and they, without touching themselves, just by feeling internally, would have to try to tap out what they think is their current heartbeat or current heart rate. And they found that people that were more accurate on that test also scored higher on empathy tests. So our ability to feel our own inner world is directly related to our ability to assess other people's inner worlds. When you say it out loud, it's not terribly surprising, but it's important that this is a measurable effect. This is a measurable effect. I don't want to get too far ahead of myself, but this goes a little bit into, as we as practitioners start working with traumatized populations, and again, probably more so in the wake of the current pandemic, one of the things that we will not be able to ignore as practitioners, folks, is observing our own reactions. Not necessarily acting on them in the moment, and more about that another day, but the more we try to cut ourselves off from our own reactions as unacceptable, the less good we are at reading other people's reactions as well. And that's a very important thing to consider when working with traumatized populations. The other thing that I want to point out here in this right brain difference, there's this sense of left brain being logical, right brain being creative, right? That's this kind of like thing that we think about, but that's a little bit too general. It's not quite exactly what's going on. A better way to look at it is that the right brain has a very Mosaic style felt sense of your environment. The right brain can kind of hear and see and taste and smell everything that's happening all at once. And understanding the relationships between things, spatially in particular, is the kind of the wheelhouse of the right hemisphere. Whereas the left hemisphere, rather than seeing a mosaic, it looks at things tile by tile. It looks at discrete packets of information, very narrow view, in order to find the important ones. Right? So while the right brain throws up this giant, beautiful picture and says, look at this picture, right? Here's a picture of a forest. The left brain says, yeah, nice forest, where are the nuts? Does that make sense? Right? So it's less about logical creative and more about broad view. And again, I'm going to keep using this phrase a lot, felt sense, versus a narrow view sifting of information. So before I go any further with that, does anybody have any questions about what we've just talked about? I understand it's a lot. It looks like, oh, someone asked me to explain mosaic sense. So a mosaic is a collection of tiles that, when viewed from a distance, make a larger picture, right? So when I say mosaic sense, I mean that when you look at a picture that is made up of many tiles, do you see what it is as a whole, or do you see the individual tiles piece by piece? Looking at that will be very different. You may have seen those composite photographs that are made up of lots of other little photographs, right? It's kind of a question of that. Do you see what the composite is supposed to be saying, or do you see little individual photographs within? Yeah, so mosaic just means big, broad sense made of lots of little pieces that you're not terribly interested in. Any else? Looks like Kate has her hand up. Kate,
yes,
please.
Yes, I was just curious, probably we've all seen this, where people come in and say, the problems are all on the left side of my body, or the problems are all on the right side of my body.
Mm-hmm.
So how does that relate to what you're just showing with the brain?
Oh, I'm so glad you asked. Yeah. Yeah, it relates a lot. It relates a lot. So I'm gonna kind of just face to face here. I'm gonna plant a little seed with this, but I want to preface by saying this is another perfect example of something that it's built into a course that I teach. This is a huge topic. We are opening a big can of worms here. So what I'm about to suggest, you may find that you have a lot more questions after I've said this. So, but I'll be as succinct as I can. So you have a right and a left hemisphere, and then you have a dominant and a non-dominant hemisphere. And for some of us, our left is dominant, and for others of us, our right is dominant. For most of us, our left hemisphere is dominant. That's why most of us are right-handed. Okay? Everyone following the logic so far there? Okay. So, real quick, someone just asked, what if someone is ambidextrous? Strictly speaking, ambidexterity has not been proven to exist. And the way that I would describe this is that when someone is because dominance is not the same as proficiency. So a neurological dominance typically informs proficiency, but a human being can become proficient doing anything with anything, right? Amputees learn to eat with their feet. And so when someone is proficient in using both hands, that does not indicate that they are dominant in both hemispheres. It only indicates cross proficiency. So the dominant neurological hemisphere is also kind of empowered with certain kind of special functions. And this mostly has to do with how we produce movement. And I'll show you when we get to the end here, I'm going to show you actually, no, forget it. Let's just open it up now. I realize why wait. Okay. So, has anybody ever seen this before? This is called the archer position. If you worked in, postnatal care or with small babies, or if you have small babies, you probably at some point have seen a child make this shape. So it's called the tonic neck reflex, and it is an inborn neurological reflection. What's interesting is that the tonic reflex that you're seeing here, it only happens on one side, and which side it's going to happen on is set at 10 weeks of gestation. Not 10 weeks after birth, 10 weeks of gestation. Which means that your neurological dominance cannot possibly be influenced by life experience. It is pre-programmed neurologically. In fact, some of the evidence emerging now suggests that it doesn't actually originate in your brain at all. It originates in your spinal cord, right? An even more primitive neurological structure. Very cool stuff. And so in this child that we're looking at right here, this child is right side dominant. This child is right side dominant. And all of the little behaviors they're doing with their limbs that I have pointed out here are deeply ingrained patterns of behavior that are part of this child's dominance, side dominance, right? So which brain is dominant does have an effect on how the two sides of the body are programmed, what the default actions are. And all right-handed people, like neurologically right side dominant people, will have the same default patterns. And all left side dominant people will have the same default patterns because they are set before you even begin living outside the womb. Now, through life experience, you learn more patterns. So it's not that you're only ever just doing these things. You amalgamate these pre-programmed defaults with new learned patterns. But here's the important part, folks. They never go away. So this pre-programming that you're seeing right now in this child, the default tonic that this child is expressing still exists in every single one of your nervous systems, in every human on Earth. And when stress goes up, or when threat goes up, this is the cool part. When threat goes up, we tend to return to the oldest patterns. As threat goes up, we take whatever the most recent pattern we learned was and say, not going to do that. That's too new. Can't trust it. Peel it back. What's below it? And if you peel back far enough, everyone is doing this. Everyone is doing what you're seeing in this little baby right here on some level. Okay? So then the one last piece to kind of hopefully tie this together here. I said before that we have this need to mutually inhibit, right? To shut down the side that is not keeping us safe. But the dominant side of the body has a very specific task, which is to keep us moving forward, to produce forward momentum. And I mean that in the most literal way, to literally produce forward momentum. And so when someone has all their pain on, or all the issues on one side, that can be for one of two reasons. One is the side that has all the discomfort is their dominant side. And what they are essentially experiencing is an intense need in order to stay safe, to keep going, even though they don't want to, right? There's a pressure to continue acting, to continue moving forward through their environment, and I mean that both literally and figuratively, even though that environment is getting increasingly threatening. And so the right side of, the dominant side, I'm a righty, the dominant side of the body has to do that in a increasingly compartmentalized way. And that generates new threats. The other version is that the non-dominant side of the body has been shut down by the dominant side of the body, has been kind of subsumed as a secondary structural support. We talked about this, I talked about the arm, right? The non-dominant arm that pins back and splints the spine to reduce your movement options. The non-dominant side of the body can wear down from doing that and generate those new threats associated with powerlessness, like we talked about before. So, I show you this because this is the great equalizer, guys. This tonic reflex right here happens in every culture, in every race, in every gender, right, in every human. And so there are things we can start to predict about the way a body moves and where its threats might come from based on this pattern. So if I know, for instance, that someone is coming in and they've got a bunch of pain on their dominant, say it's their right side. I got all of this pain in my right side. Well, one of the things that I may try to do is say, okay, I'm going to assume that it's your right side. Say they say they're right-handed. Now, that doesn't necessarily mean they're right side dominant, but that's a discussion for another day. But let's say, okay, I'm going to assume they're right-handed, all their pain's on their right side, so I'm going to go to one of these things that I've pointed out here for you. And I'm going to say, all right, what happens if I release or start to act on some of the tissue that does this stuff? What if I start to release this tonic? How does that body respond? And in one case, if it truly is their dominant side, I can expect that we will see sympathetic nervous system behavior start to return. Or we will encounter pain. If I try to, if I have the wrong side, right, if it's not their dominant side and I start releasing stuff, but it's stuff that's already really released, we may encounter pain because I'm taking them further into threat. But suddenly I'll know something about what really threatens them. In my program, we call these subversions, where we take the default programming of the system and we do the opposite and then observe the reaction and use that reaction as a data point.
So really quick, could you in like one sentence, 1 to 2 sentences, I'll give you a little space, describe specifically the difference between the way you see a presentation entirely on the non-dominant side versus entirely on the dominant side in terms of dysfunction?
Yeah, so the dominant side of the body will tend to present as rigid, stiff, aggressive. The non-dominant side of the body will tend to be more malleable, will tend to be more desensitized. And if I could give a kind of qualitative view, the non-dominant side of the body, if we have, on one end, we have rubber, on the other end, we have like taffy. The dominant side would be more like rubber, the non-dominant more like taffy. The elasticity, the reactivity in the non-dominant side of the body will tend to go down. The dominant side will tend to go up. Again, this is all contingent on as threat increases. Okay, so I'm gonna pause there for a second because I see some things have come up here. Was that the tonic neck reflex initially? Does this include the neck rotation as part of that as well? Yes, it does. Yes, it does. That head turn, turning the head toward the non-dominant side, is part of the tonic reflex. And so a cervical turn toward the dominant side will in fact tend to be quite threatening for people. And so a really interesting place to play. Matter of fact, funny story, I was telling you that case study before about my client who I was manipulating their head and neck, and they said they were fine, but their face was freaking out. What we were doing was playing with their tonic head turn. And as we turned toward their dominant side, they were like, oh yeah, this is great. And their face was like, stop, stop now.
No, it's not.
All right, let's see what else do we have here. Do you find this rigidity in the antagonistic muscles of the dominant tonics? Excellent question, Jesse. And the answer is yes, but what's interesting, and you guys probably know this already, but let's just say it out loud. Muscle tension can come in different forms. And I find it useful to divide muscle tension into 2 broad categories. One is a kind of concentric tonic tension, where this muscle is tense because the brain is telling it to be short. And there is a steady stream of information coming from the brain saying, stay short, stay short, stay short, stay short. And that feels a certain way. Then there is tension that the antagonist of that muscle will be experiencing, or the non-dominant version on the other side, which is it's been held at an elongated position for so long that the nervous system has turned down the elasticity of the muscle. Okay, remember folks, elasticity is not an inherent quality to muscle. Elasticity is granted by the nervous system. And so those antagonist muscles sure will feel tight and ropey, but it's not because they're stiff, it's because they're inelastic from a period of long held positions.
Hi, Bears.
Let's see, what else do we have here? You were saying something about non-dominant side has shut down the dominant side for the body's option on the non-dominant side. Could you repeat that, please? Yeah, so think of it this way. The dominant side's task, let's look at this in terms of task. The dominant side's task is to keep you going no matter what. Keep going, keep fighting, keep pushing, get the job done. The non-dominant side's task, when things are good, when stress is low, is to help you upload more force from the environment, gravity and friction. When things are bad, when we're heading towards shutdown,
more stress state.
More stress state, The non-dominant side's job is to make it harder for you to keep going forward. Okay, so a lot of that splinting action on the non-dominant side it's a gradual shift where the non-dominant side is saying, okay, dominant side, I see that you have to keep going, and I'll let you keep going, but I'm going to keep limiting more and more and more and more how you keep going. And eventually, when you can't, we're in total shutdown. Non-dominant side becomes the winner, if you will, and we collapse. Kate, I see your question. Go ahead. Oh, hold on. You're not unmuted yet. I thought you were. There you go.
Okay.
Good.
So in your training, are there different ways that you work with these sides specifically?
Yes, many. So we have manual, verbal, cueing, all different kinds of stuff. Like we have tons of different practices. We will either enhance or restrict different senses. We will focus on different kind of like brain functionality in order to create more separation or marriage between hemispheres. Yeah, it's a big part of the work we do.
Thank you.
So yeah, I want you guys to know that while, as I'm just kind of dumping this information on you here, this may seem like a lot, but this is organizable, actionable information. And for those who are interested in exploring this, again, we were going to be offering my apprenticeship course at the Oregon School of Massage until the COVID shutdown. May 6th was supposed to be the first day you could take my course through OSM. But I'm still doing these courses starting in September. The plan is that September and November, we've got 2 lined up. There's a level 1 in September, and then there's a level 1 and a level 2 back-to-back happening in California in November. Now, again, obviously that's contingent on what the world is like at that time, but that's the plan. The plan is that's where we're going with this. So if you would like to find out more about exploring this stuff in detail with me, obviously you can send an email to Azara. I'll put up actually our contact info here in a second.
I want it.
You got it? Okay. And so that you can get more information about this. But it's, we've had massage therapists, naturopaths, acupuncturists, yoga therapy, like everything, all wellness practitioners. And it's been a really powerful way to trim your assessment process and be very effective in this kind of work, especially in trauma-informed work. So it's called the Reembody Method Apprenticeship Course or Apprenticeship Program. Right? The RCA stands for Reembody Certified Apprentice, and that's the level 1, the RCA.
There's a link in the chat window, guys, if you're curious.
Yeah, so Ray Sidarius is pretty excited about it, and we had a really great time kind of adapting it for the OSM protocol, and I was pretty bummed that we're not going to be able to do it this quarter, but it will be back. It will be back for sure. Okay. So the recording of all this is going to be available. So if you missed something here, or if you're like, what the hell is even going on right now, don't worry. There will be something you can revisit in order to listen to it again. Also, again, I do private sessions online, and I have been for years. So if you would like to personally explore this with me, either kind of for an educational opportunity or for your own kind of personal, like as a client, please don't hesitate to contact to schedule sessions. I'm 100% open for that. Someone else had a question. Elasticity and it being granted by the nervous system. Do you feel that NMT or training memory would be effective? Yeah, NMT, neuromuscular therapy. There you go. Is a great protocol. Actually, I also have some.
Muscle memory. Training muscle memory.
Oh, training muscle memory. I mean, yes, kind of. Remember that muscle memory can be just in one hemisphere, right? We can train something and have it be felt in the muscle tissue, but that doesn't mean that we've generated a kind of bi-hemispheric felt sense. So muscle memory can be part of it, but not the end of the story. Any other last questions? Anything else you want to explore before we wrap up today?
I have a quick comment. If anybody else wants to go.
I just want to say something real quick.
Please.
If I'm going to invite people to have feelings in my office or invite, emotional release, I feel it's super important to have some skills about, being able to down-regulating that system too. So just, that's a really important piece of working with emotional states that we didn't get into here. And obviously you could spend hours and hours talking about it. But.
Yeah, and I hope, if anything, that this course has encouraged all of you to explore more of those skills. Because there's lots of ways to enhance those skills. You're absolutely right. But yeah, it's not a nice place to be where a client is having an emotional reaction. I'll put it to the crowd. Has anybody ever had a client have an emotional reaction on your table that you were not prepared for, or that you felt blindsided by or frightened of? Yeah, it's happened to me. Definitely happened to me. And so there are several ways of developing that resiliency. The seed that I'll plant right now is that the most powerful tool you have in that process is your own understanding your own emotional signals. Because if your fear over something starts to spike, then you're mutually feeding each other. But if your emotional signals can be regulated and understood, and you're good at navigating those, have experienced navigating those, that will be necessarily easier navigating other people's difficult emotional experiences. That's not the only tool. You need more than just that, but at some point you need that. Someone asked me to explain subversion again briefly. So subversion would be, if we just take the tonic neck reflex and assume that that is a default musculoskeletal action, then a subversion would be encouraging the opposite of that action. So an example would be the non-dominant elbow tends to flex. So as stress goes up, movements that require that action or can anchor off of that action will be more utilized. So if I encourage an action that leads the elbow into extension, and then I try patterning them with more elbow extension, how does their body respond? So I take whatever the tonic reflex says, and I introduce its opposite in order to observe the reaction. Not because the opposite is better, but because I want to know what the sympathetic nervous system response in its wake looks like.
That's all.
Okay, anything else?
I know we're well past time, but I wanted to just say thank you to everybody who made it through our courses. This is the last day on the last class. I'm very excited. This whole CE course was sort of my brainchild, and I'd be curious to know, it's basically like a pilot program. What do you think? What worked? What did you like? What didn't you like? What stood out? What did you want to see more of? So I'm about to send out a Google form survey real quick, like 10 questions, just kind of like general impressions, things you'd like to see more of, less of, etc. So if you have a, eat a sandwich, come back to your computer, give me like 3 minutes of feedback, and then you're free to go. I will say she worked really hard on this, guys. She worked really hard on this. Nothing else to do. School is closed.
Your feedback would be extremely important, extremely valuable to us.
And I also wanted to mention, nope, well, it's gone.
All right. Thank you, everybody.
Thank you. Oh, certificates, coming next week. That's what I wanted to say. Okay, bye.